In this video, I will demonstrate how to perform an ultrasound examination of the shoulder. Following a sequence of steps will ensure a complete and thorough evaluation. The shoulder ultrasound examination can be divided into 5 steps. Step 1. Evaluate the long head of the biceps brachii tendon. To begin, ask the patient to place the hand palm up on his or her thigh. This position rotates the bicipital groove anteriorly, which is an important bone landmark. The transducer is placed in the transverse plane over the anterior shoulder, slightly inferior and lateral to the coracoid process. The long head of the biceps brachii tendon is identified as an oval-shaped hyperechoic structure lying in the bicipital groove. The transverse humeral ligament is a hyperechoic fibrillar structure with a thickness of approximately 1 mm, overlying the biceps brachii tendon between the lesser tuberosity and the greater tuberosity of the humerus. Because the tendon sheath of the long head of biceps brachii tendon normally communicates with the glenohumeral joint, increased joint fluid can be found in this tendon sheath at the level of the bicipital groove. The biceps brachii tendon is evaluated in short axis from proximal to distal. Because the distal biceps tendon course is deep, tendon obliquity to the transducer sound beam commonly creates anisotropy. This is corrected by toggling the transducer to aim the sound beam superiorly. Evaluation is continued inferiorly to the level of the pectoralis major tendon, because complete biceps brachii long head tendon tears may retract to this level. Next, the transducer is rotated 90 degrees to visualize the long head of the biceps brachii tendon in long axis, with the normal tendon appearing hyperechoic and fibrillar. Step 2. Evaluate the subscapularis tendon and exclude biceps tendon subluxation or dislocation. The transducer is placed in the transverse plane as before to first visualize the bicipital groove, and then the transducer is moved medially over the lesser tuberosity. In this neutral position, although the subscapularis tendon can be seen in long axis, there is significant anisotropy. Now ask the patient to externally rotate the shoulder to pull out the subscapularis tendon from beneath the coracoid process. The normal subscapularis tendon is now seen in long axis as a hyperechoic fibrillar structure inserting on the lesser tuberosity of the humerus. The transducer is then moved superiorly and inferiorly over the lesser tuberosity to ensure complete evaluation of the subscapularis tendon. Move the probe medially on transverse planes to assess for subcoracoid bursa. The coracoid process appears as a rounded hyperechoic structure. The transducer should also be moved laterally over the bicipital groove to evaluate for potential biceps brachii tendon subluxation or dislocation, which may be present only in external rotation. Then we center the transducer over the distal subscapularis tendon again, rotate the transducer 90 degrees, and assess the subscapularis tendon in short axis. A normal subscapularis tendon appears as 3 or more separate, round, vesicular hyperechoic structures. In this view, it is common to see hypoechoic striations of muscles or interfaces between the several tendon bundles. Step 3. Evaluate the acromioclavicular joint. With the patient in neutral position, the acromioclavicular joint can be located with palpation of the distal clavicle and placement of the transducer in the coronal plane, parallel to the acromion and clavicle, on top of the shoulder. The acromioclavicular joint is identified by hypoechoic joint space and bone landmarks, the acromion and the clavicle. The superior acromioclavicular ligament forms the upper border of the joint capsule, appearing as a hyperechoic band-like structure. The meniscus appears as a hyperechoic wedge-shaped disc. The normal acromioclavicular joint has smooth cortical margins with no more than 3 mm of hypoechoic joint capsule distension. Assess this joint for bone contour irregularity, which is suggestive of degenerative change, and look for synovial hypertrophy or bulging of the joint capsule as well. The acromioclavicular joint could also be widened, which would indicate joint disruption. Step 4. Evaluate the supraspinatus tendon and subacromial subdeltoid bursa. Most rotatory cuff tears involve the supraspinatus tendon, although they may extend posterior to involve the infraspinatus and anterior to involve the biceps reflection pulley and subscapularis tendon. To begin, ask the patient to extend their arm posteriorly and place their hand on the ipsilateral iliac crest with the elbow flexed and directed posteriorly. With this maneuver, commonly known as the modified crest position, the supraspinatus tendon is pulled out from beneath the acromion. The transducer is placed on the rounded contour of the interior shoulder, parallel to the long axis of the supraspinatus tendon, in a posteromedial to an anterolateral orientation. In long axis, the normal supraspinatus tendon will appear as a bird's beak and is hyperechoic and fibrillar, with a convex superior margin. The tendon overlies the humeral head with a thin layer of cartilage in between, and inserts on the cartilage-free greater tubulosity. The deltoid muscle overlies the supraspinatus tendon. The sonographic pattern of a normal subacromial subdeltoid bursa is characterized by a hyperechoic structure positioned between the deltoid muscle and the supraspinatus tendon. The thickness of the bursa should be no more than 2 mm. Accumulation of bursal fluid inside the potential space separates the two opposite bursal walls and renders them differentiable. The supraspinatus tendon inserts on the superior aspect of the greater tubulosity. The transducer should be moved anterior and posterior over the greater tubulosity to ensure complete evaluation of the entire width of the tendon. The transducer is then turned 90 degrees, perpendicular to the long axis of the supraspinatus tendon, to evaluate the tendon in short axis. Start scanning immediately distal to the acromion, and move the transducer from the proximal to the distal, and scan the entire length of the tendon. The sonographic pattern of a normal supraspinatus tendon in its short axis view is characterized by a rainbow-shaped, homogeneously hyperechoic structure covering the humeral head. Medial to the supraspinatus tendon is the oval-shaped, hyperechoic long head of the biceps brachii tendon. The coracohumeral ligament appears as a thin, hyperechoic layer overlying the biceps tendon. A supraspinatus tendon that has a thickness over 8 mm is considered abnormal. As the transducer is moved more distally, the supraspinatus tendon gradually tapers and inserts on the cartilage-free greater tubulosity. Step 5. Evaluate the infraspinatus tendon, teres minor tendon, and posterior glenohumeral joints. Ask the patient to place his or her hand on the contralateral shoulder so that the shoulder is adducted and slightly forward flexed. Place the transducer in the oblique axial plane, angled superiorly toward the humeral head, parallel and just inferior to the scapular spine. Slightly rotate the transducer to make the transducer parallel to the long axis of the infraspinatus tendon. In long axis, the infraspinatus tendon overlies the humeral head, appearing as a beak-shaped hyperechoic fibrillar structure. The infraspinatus tendon can then be followed distally to its insertion on the medial facet at the posterior aspect of the greater tubulosity. The transducer can then be moved inferiorly to visualize the smaller and thinner teres minor tendon. It is a hyperechoic fibrillar structure that inserts on the inferior facet of the greater tuberosity. The hypoechoic muscle portion can also be seen. The transducer is then turned 90 degrees to evaluate the infraspinatus tendon and teres minor tendon in short axis. The tendons of the infraspinatus and teres minor usually cannot be distinguished in short axis view. Proximally, the infraspinatus muscle and teres minor muscle appear as two distinct, oval-shaped, hypoechoic structures separated by a hyperechoic fascia. To complete the posterior shoulder examination, we evaluate the posterior glenohumeral joint and related structures. The patient assumes the same position as that while checking the infraspinatus tendon. The transducer is placed in the transverse plane at the posterior shoulder over the glenohumeral joint. The posterior labrum appears as a triangular hyperechoic structure extending from the glenoid and covering the posterior humeral head. The patient can actively internally and externally rotate the shoulder to assess the infraspinatus tendon and posterior glenoid labrum dynamically. External rotation improves visualization of joint fluid distension of the posterior recess. This concludes the standard shoulder ultrasound examination.